the history of valve surgery goes back pretty far, and the first successful valve replacement was in the early 1950s with the Hufnagel valve, and this was a silastic ball in a tube, and it was actually placed in the descending aorta because we really didn't have the ability to safely stop the heart and go on cardiopulmonary bypass yet. But you can see the positioning right here in the descending aorta, and it really only helped aortic insufficiency of blood coming back from the lower body. All kinds of iterations of valves. The Starr-Edwards is really the one that started things off successfully, and there have been numerous reports of 40-year outcomes with Starr-Edwards valves, and they had excellent results. But there were certain iterations that where they thought they were making things better, where they actually made things worse. And I think the most important thing about valve choices is learning from our mistakes, and as we move forward with TAVR especially, learning that every good idea doesn't always come to fruition. So they had some trouble before with the silastic ball getting chipped away in these metal struts here, and so they decided to cover it with Dacron. Well, that didn't do real well. So you may have seen some of these Dacron in the carotid arteries and in the brain. There's a disc in cage, excuse me, a disc in cage valve, and they didn't realize that the material, once it was inside the human body and moving in and out, would start to dissolve like a Certs, and it kind of dissolved like a lifesaver, and it would slip out of the cage and go elsewhere, go flying down the bloodstream. So there's been a number of things that have come up over the years where we learn from our mistakes. Hopefully we can be preemptive as we go down this TAVR path and try not to fall into some of the same traps. The valve choices we have, obviously if it's an aortic valve, we always try to do a native valve repair for aortic or mitral if possible. We can use either a prosthetic or a tissue valve for aortic valves. The prosthetic valves now, the ones that are still being used, are bileaflet or ball cage valves. We don't use too many tilting disc valves anymore, although we see a lot in the operating room still. Bioprosthetic valves can be split into stented or stentless. The stented valves are pericardial or porcine valves of various iterations, and there's a number of stentless valves that have come and gone over time. Homograft valves, pulmonary autograft. I was not named after the Ross procedure, and it's not named after me, but another Arnold Schwarzenegger reference, but we won't go there. Transcatheter AVRs, we can do it through various different approaches and various different types of valves. And we've talked about the mitral repairs in others' hands when they can't repair a valve. They can replace it with either a tissue or a prosthetic valve. These are some of the different bileaflet valves: the Onyx valve, the Carbomedics, and the St. Jude valve. St. Jude's kind of the tried and true that's been around for 40 years or so, and you can use it as a valve conduit or as a freestanding valve. And some of the valve hemodynamics: this is the ball cage valve. It caused a lot of turbulent flow, and most of these patients were kept with an INR of around 4 to 4.5, and occasionally the ball would swell a little bit and get stuck in the poppet, and there were different problems with it. But Albert Starr published a paper recently with the 40-year outcome and said that the Starr-Edwards valve should be the gold standard against which all other valves should be compared. This was the tilting disc valve, and it had some issues with changes they made to the structure of the valve, and ultimately came off the market. And the bileaflet valve is really the one that we use most often when we use a prosthetic valve. But the Achilles heel of the prosthetic valves are that the materials, the moving parts, the pivots and struts and things are inherently thrombogenic. So anywhere where blood stagnates or it's on an artificial surface, it can clot. So these valves are prone to clot. We did see a patient with a Cooley cutter valve, which is a terribly thrombogenic valve. About 30 years later, he came into Dr. Cooley's office, and they asked him what his warfarin dose was, and he said, "What's warfarin?" Had never heard of Coumadin before, and so somehow he made it 30 years and didn't get a clot. But it was really loud. You could hear it walking in the room. So this is warfarin. It's a pill you take every day, and for a lot of patients, they tolerate it really well, and they have no problems whatsoever, and it's really a great drug for a lot of people, but it is rat poison, and it does have complications and problems. So there are thousands of patients out there with mechanical valves that do very well with them, but because of the clotting issue and the Coumadin and all the problems there, when tissue valves were first developed in the 70s, they thought they had come up with the ideal valve, and they thought these were valves that would just replace all your valves and everything would be fine. It wasn't until decades later that through Dr. Lowry and other people started studying and realizing that replacing the dynamic structure of a biological valve with a stented tissue valve is probably not the best physiologic outcome. And then these are various types of tissue valves. We have all kinds of porcine valves, which are made of a sewing ring and a stent and porcine leaflet tissues. We have pericardial valves, which are made of bovine pericardium in different iterations. We have the externally wrapped valves, which have a larger orifice area, and some of the sutureless or minimal suture valves that also have a larger orifice area. This one was recently FDA approved. The Percival valve was recently FDA approved. And the hemodynamics of the pericardial and the porcine valve, you can see the different vortexes in the vortices and the flow patterns are a little bit different. That's a bad sign. Oh, good. Okay, so the Achilles heel of the tissue valves is that we found out that they can break down over time. A lot of the issues, there was a paper by Enescu who said that he has this valve that never breaks down, and it's out to 7 years now, and they've had almost no degeneration of the valve. And now at 7 years, he suggests that it should be put in everybody from 5-year-olds all the way up. And so he was putting his valve into children and young people, and about a year after that paper came out, the Texas Heart Institute put out a paper of their 1,200 Enescu-Shiley explants of degenerated valves. So nothing is perfect except what we came with, and so the degenerated valves have been the Achilles heel of the tissue valves. A lot of design problems, a lot of things where they thought they were making things better, the way that they fixed the valves, the way that they stored the valves. A lot of things we found out later were not very helpful. Sometimes just changing the height of the struts or changing the material that make the struts can cause stresses on the valves that they didn't predict. And so a lot of the reasons that valves fail have to do with the construction. But there are also biological mechanisms, and we found Jameson and some other people found out relatively early on that there was a discrepancy in the age at which your tissue valves failed. So if you're 75 or older when you get your valve, typically you can last 10 or 15 years with that valve with about a 90% freedom from failure rate. The aortic valve fails less often than the mitral valve. Mitral valve bioprosthetic will fail more quickly, and I've got some follow-up figures that show that. Different generations of the valves have had different iterations of the fixation process, from high pressure fixation that had basically folds in the leaflets which would later fail because those folds would calcify and tear, to low pressure fixation to physiologic fixation that has better outcomes. And different from no anti-calcification treatment to anti-calcification treatment, there have been some improvements with later generation valves. Third generation valves, looking at the age discrepancy in the longevity of the valves. The older you are, the better chance you are of getting 10 to 15 years out of your valve. And over the years, there's been a shift in the preference of surgeons and patients and cardiologists for tissue valves versus mechanical valves. This is an old slide, but in 1995, about 2/3 of the valves were mechanical, 1/3 were tissue, and within 6 years, that had completely reversed, and that trend still continues to, the two curves are diverging. Now in the STS database, a couple of years ago, 80% of the valves that were implanted were tissue valves, 20% were mechanical valves. And in Europe, it's even steeper change. And this shows some of that data. You can see the tissue valves have been increasing in the number of procedures, while the mechanical valves have gone down a little bit. Part of the reason, a very small part of the reason, because that the study I showed you before came out even before we were thinking about valve and valve. But a lot of people now think, well, you can get a tissue valve because in 10 years you just get a valve and valve, you'll be fine. But you're going to hear soon about some of the problems with valve and valve procedures, and that it's not just a quick fix, and you can't just rely on the fact that you're going to get a valve and valve later because it's actually quite tricky. But that is one option that people are thinking about, and the more as we get surgeons to start thinking about it, when they put in a tissue valve now, they have to be thinking about the next procedure down the line and put in the right size, right type of valve for a valve and valve if that's going to be necessary later on. So we talked about the age difference in the longevity of the valves. This study was an early randomized trial at the VA in patients who had a mean age of 59 years old, getting a Bjork-Schiley versus Hancock valve. And this was unadjusted, but you can see that the survival rate was very similar whether you had an AVR or an MVR with a tissue valve or a mechanical valve. They saw no difference in survival with the tissue versus mechanical valves. But what they did see was that there was a significant increase in the bleeding risk if you had a mechanical valve, and a significant increase in the reoperation risk if you had a tissue valve. And that was one of the earlier studies that showed us that result. This other study came out and said that there was actually a huge difference whether you got a mechanical valve or a bioprosthetic valve in survival. But if you look at the start of the curve here, this kind of starts to tell the story here. This is an unadjusted trial. It was not randomized. It was retrospective and unadjusted. And the patients who got tissue valves were much older, much sicker than the patients who got mechanical valves. So I showed you the slide earlier that showed that the older the patients are, the more rapidly they die after an AVR of any kind. More recent New York State Registry trial by David Adams and his group showed patients who were 50 to 69 years old when they got their valve. Over 15 years, there was no significant difference in overall survival. And this was a propensity-matched retrospective trial, not a randomized trial. But he saw no difference. But just like the VA trial, he also saw that there was an increase in reoperation rate for bioprosthetic valves. But just because you got a mechanical valve doesn't mean that you didn't get a re-op. So you have to keep in mind, you make sure that patients don't get the impression that if they get a mechanical valve, it means they can never have a reoperation. Sometimes patients build up pannus, they get a clot or they get an infection, and they may need to have a reoperation. Also, the bleeding risk was higher for the mechanical valves, as we expect, because they're on Coumadin, but a lot of patients with tissue valves are on Coumadin also. And so you can have bleeding, you can have thromboembolic events with tissue valves as well. But it is a significantly higher risk with a mechanical valve. So there have been, I could have shown you about 10 different studies just like that, a retrospective trial and several randomized trial, meta-analyses that show a very similar survival similarity between tissue and mechanical valves. So there really isn't a big difference in the survival rate, whether you get a mechanical or a tissue valve, even if you're in your 50s or 60s. But it comes down to, if the survival is equivalent, it comes down to choosing the valve type based on your quality of life and what you want to do. So quality of life after a mechanical valve, just take a pill every day, but you get blood tests. You have to be kind of tied to a Coumadin clinic and or home PT monitoring. There's all kinds of drug interactions. Everything that you can ever take interacts with Coumadin in some way. If you take antibiotics or change your diet intake of vitamin K rapidly, you may have differences in your INR levels. If you need emergent surgery, you have to reverse the Coumadin. If you have a trauma, sometimes you have to bridge with Lovenox. Sometimes you travel a lot. I had a patient who was in the outback for 6 months out of the year, no access to a doctor. So at 35, he got a tissue valve. If you're out at the ranch, it gets disruptive. Also, patients complain of the mechanical valves clicking a lot occasionally, but some patients don't have any problem with it. And there's been a lot of patients that were so anxious worried that they're going to get a clot at any minute or they're going to have a brain bleed at any minute. So you have to take into account that the complications that come from a mechanical valve, even if it's 1% per patient year, can be quite devastating. And so you have to take that into account when you counsel your patients. With a tissue valve, the risk of reoperation is about, for an aortic valve position, it's about 12 to 30%, depending on how old you are over 15 years. So that means anywhere from 70 to 90% of the patients won't need a reoperation at 15 years. Are you going to are you going to outlive your risk of a redo or not? You have to think about the risk of reoperation mortality, about 5 to 8%, depending on the study. Older patients have a higher risk. And if you have a major bleed, your mortality is about 7.5% if you're on Coumadin. If you have a stroke from a mechanical valve, the mortality from that stroke is about 8.5%. So that outdoes the risk of reoperations. If you have a sudden valve thrombosis, the mortality can be in excess of 60 to 80%. This slide opened my eyes a lot years ago, and this shows you the area under the curve of patients who are living free of complications. And so the first thing you do is you take out the patients who had valve-related deaths. It was about 21%. Take out about 1% per patient year of reoperations for endocarditis, about the same for thromboembolic events, bleeding events, and patients who died in a car wreck or a house fire or something. And by the time you get out to 15 years, the patients who got a prosthetic AVR, there were about 23% of them still alive, reaping the reward of not having the risk of a reoperation from their tissue valve. So not all of the mortality was due to their mechanical valve or Coumadin or anything else, but these are the patients that are trying to benefit from the longevity of not having to worry about a reoperation in 15 years. So we also know that the risk of explant for structural valve deterioration is higher the younger you are. Size matters. The effective orifice area of the valve is important, whether it contributes to your survival, your quality of life, or the risk of structural valve deterioration down the line. And this study showed AVR survival by valve type. The mechanical valve had a better overall survival, which goes against some of the other studies we've seen. But when they looked at the effective orifice area, the mechanical valves had a much better effective orifice area. The tissue valves had a much lower effective orifice area, so that may have contributed to the early decline. We also know that the higher your aortic valve gradient over time after surgery, the more likely you are to develop structural valve deterioration. Some of the stresses that you were talking about with the mitral valve also occur in the tissue valves. So don't forget about aortic root enlargements. Don't put in too small a valve. You can use mechanical or tissue valves that have an increased orifice area or a stentless valve. And the Ross procedure is nice for kids, but you're turning a one valve operation into a one valve problem into a two valve problem. And we'll talk about TAVR in a minute. So in summary, selection of the AVR or MVR types is dependent on several patient characteristics. You have to think about age, childbearing status. If you're going to have a mechanical valve and you're a young woman, are you going to be getting pregnant, have to be on Lovenox or be in the hospital on a heparin drip because Coumadin is teratogenic? What is your expected lifetime? Think about the etiology of the valve disease, suitability for conventional AVR or access for TAVR, annular size and patient size, and take into account the patient preference as well.